Well, thank you for standing by. All participants will be in listen-only mode until the end of the presentation of today's call. Questions will be taken at the end. You may press star 1 to ask a question. Today's call is being recorded. If you have any objections, you may disconnect at this time. Now, I will turn the meeting over to your host, Ms. New. Ma'am, you may begin.
And thank you everyone for joining us today on our Midwest Quarterly Stroke webinar. My name is Renee Sednu, and I am a Quality and Systems Improvement Director in Illinois, focused on stroke and atrial fibrillation, and I am joined by my colleague, Lynn Serdinsky, who is a Quality and Systems Improvement Director in Wisconsin. So as a reminder, here are the login instructions. We ask you both click on the web portion and also call in. We've included the participant passcode. If you have any questions or technical issues, you can contact Margarita Avila, and I've included her email address on the screen. Lynn and I will be able to answer questions at this time. So we're to bring you these Midwest Affiliate Stroke Quarterly webinars are open to anyone interested in improving stroke care in the Midwest and also in other states. We've had some other states join us, so we're happy to have anyone with us. Purpose is really to engage in educational opportunities, share best practices, and to hear from content experts. They occur every quarter for an hour, and our next webinar is going to be October 4th, and included a link to the registration. And anyone should have received a PDF of these slides prior to the webinar, and we will send another one afterwards. We have an optional stroke networking group where you can connect directly with other hospitals to share best practices and network. If you'd like to join, please contact myself or Lynn. And our current membership is 360 participants. So thank you to everyone who has joined the networking group. Today to have our speaker, Dr. Shyam Prabhakaran, and we're going to hear from him in a few moments. He's focusing on the 2015 lines for TPA inclusion and exclusion. So we're pleased to have him here today. Leaving as one of your attachments in your reminder email, this article that Dr. Prabhakaran will reference a few times during his presentation. Today we're focusing on the reasons for no TPA, so we're going to look at those guidelines and try and get a better understanding of the inclusion and exclusion criteria, and also to provide our audience with ways to do some performance or quality improvement using with the guidelines reporting function. So what we're looking at right now is a chart of aggregate data for all Midwest hospitals participating in Get With the Guidelines stroke. This is 2017 data year to date. And as you can see, the two most commonly selected reasons for no TPA are rapid improvement and mild stroke, and we're going to take a closer look at that today. And a reminder, this is a report that everyone who uses Get With the Guidelines has access to for your individual hospital and for this Midwest region hospitals benchmark and in the Midwest. So we know how to review all of the reasons for TPA, all of the definitions and descriptions. So they're available through the coding instructions. You can access the coding instructions a few different ways once you're logged in to Get With the Guidelines. The quickest way is clicking on the header when you're in the patient management tool entering data. Clicking the header that says IV thrombolytic therapy, and then you can select from those bullets the contraindications or warnings and view examples, definitions, and notes on each of those reasons. Walk through how to generate this report for your individual hospital. So you can access reports from two different places, from the Reports tab or from the bar chart icon from your community page. So just starting out by clicking on one of those two items, you select Configurable Measure Reports. A reminder, these reports are real-time and they're a great resource for you to use there with your stroke team, with any hospital leadership. You can generate bar charts, line charts, and configure them the way that works best for you. If you need any assistance with this, reach out to your local Quality and Systems Improvement Director. So one Configurable Measure Reports, you're going to click on the drop-down for Get With the Guidelines Standard Measures. And the most current report that we're using is the Reasons for No TPA. So time to time, just as a note, from time to time, the patient management tool is updated to reflect the most current terminology and definitions. So there's a similarly named report to above the highlighted one you see on your screen called Reasons for No TPA with the parentheses contra warning. This report is outdated just as of April 2016, but will still be available for historical review. So it happens, it's updated from time to time just so we have the most current science on our tool. Once select that option, simply click Generate Report and you will see a bar chart for a hospital that's similar to the one that we looked at for Midwest region. So do the same. If you would like to take a closer look at individual patient records, we want how to generate that report. So you would click on Configurable Measure Reports and your time period and also that same Reasons for No IV TPA. Under Format, instead of bar chart, you can select Patient Records. And do is generate a table that has the individual patient records for this report, and you have the ability to export to Excel. So this might be useful if your report is not looking the way you expected, or you wanted to really investigate each of the patients that are listed under certain reasons. So next, to introduce our speaker, Dr. Shyam Prabhakaran. Dr. Prabhakaran has a long track record in stroke systems and quality research in acute stroke treatment. Currently, he is the Director of Stroke Research at Northwestern University's Department of Neurology, where he oversees and leads multidisciplinary research efforts related to acute stroke treatment, secondary prevention, and stroke recovery. Additionally, Dr. Prabhakaran is a National American Heart Association volunteer and member of the Get With the Guidelines and Target Stroke Steering Committees. He's the physician champion for American Heart Association's quality enhancement for speedy thrombolysis and stroke, which is a Genentech-funded quality improvement initiative aimed at both reducing door-to-needle times in Chicago area hospitals, as well as assessing factors associated with sustained reductions in thrombolytic therapy. Pleased to have Dr. Prabhakaran with us today. Dr. Prabhakaran, you may begin.
Thanks, Renee, for the kind words, and Lynn and the organizers for the invitation today. It's a pleasure and honor to talk to this group. I'm going to speak to the topic that Renee alluded to, which is trying to understand some of the exclusion criteria for PA so that we can have a better rationale for hopefully including more patients rather than excluding more patients from TPA. So with that, I'll get started. So this slide, I'll ask Renee to forward. Yeah, thank you. So this audience knows this very well, but to reemphasize and make sure that we're all on the same page, we know that time is brain, and that can be measured tissue brain imaging. You can measure it by looking at number of cells that are dying or connections that are lost. Of course, it can be translated into outcome insofar as quality of life and disability. So we know that every minute does have a translated effect on patient outcome. Next slide. The study that we all rely on, I want to review briefly, and why drug should be provided to our patients. The NDS-TPA trial was randomized, a double-blind trial. It had two parts. In fact, it was two trials at one. One an early improvement trial, and the second one was a three outcome trial. And they were really phenomenal and groundbreaking at the time. Go to the next slide. They set up very important criteria. A lot of them were based on expert opinion at the time. They based it on multiple prior preliminary data, as well as the experts in the stroke community who together and came up with the inclusion and exclusion criteria for the trial. And those included some of the items for eligibility listed here, such as having an onset, a clear defined onset within 3 hours, a negative CT, of course, not showing hemorrhage, adults age over 18, and mild severe symptoms. So you can imagine these were investigators with lots of experience who came up with the area. But they were doing the best they could to ensure that they had a trial that was going to be safe and potentially efficacious insofar as finding a benefit. So they really narrowly defined the population that they wanted to study. Next slide. They included a lengthy list of exclusion criteria. These were, again, predominantly based on expert opinion, wanting to ensure that the drug wasn't given to people in whom harm might be seen, or in people who may not be having a stroke at all. And so you can see some of the rationale behind why they did this in the 1990s. I've highlighted quickly going back. I've highlighted the ones in the box that I'm back to that are in many ways the one that we fear the most, and I'll briefly mention how in the newest guideline statements, those have remained as contraindications, while others that are listed outside the box have left some room for debate, especially since there has been accumulating observational data that for these situations it may be better to consider giving TPA rather than upholding it. Next slide. And of course, not to belabor this, the treatment with TPA in the trial and ever since has been very standardized and protocolized. And so the protocol must be adhered to for the results to be similar to what was seen in the trials and subsequent large studies. 0.9 milligrams per kilogram dose, 10% as an IV bolus over 1 minute, and then 80%, the remaining, over 1 hour. And the maximum dose could be only 90 milligrams. And then post-TPA, very importantly, there were real strong recommendation from the trial that there be very strict adherence to avoidance of blood thinners, any blood thinners, for 24 hours to prevent interstitial hemorrhage from occurring. Also keep blood pressure very strictly controlled post-TPA, again, to prevent the adverse event of interstitial hemorrhage. Next slide. Of course, the outcomes were tested at 24 hours and at 3 months. At 4 hours, it's often cited that TPA didn't work. Well, they used a pre-specified cut point of a greater than 4-point improvement in the NIH stroke scale score at 24 hours from baseline. And as you can see here, the TPA group did have a higher absolute rate of improvement compared to the placebo group. However, none of those reached statistical significance. In subsequent studies of this retrospective and post-hoc after the trial was published, they looked at other cut points. Had they chosen any other cut point, 5, 6, 7 points, 8 points, 9 points, 10 points as measure of improvement at 24 hours, this 24-hour outcome would have also been statistically significant. So they actually just had to choose 4 points as a pre-specified endpoint, and they did not meet it. But it doesn't mean that it doesn't work early. In fact, it probably does, given the half-life of the drug and the way we know it can improve outcomes had they chosen a different cut point. Go to the next slide. This was translated into better functional outcomes, lower disability across all of the different scales, including the NIHSS, the Bell, the Modified Rankin, Moscow Outcome Scale. And you can see roughly the same difference in placebo versus TPA, roughly around 12% or so absolute benefit of TPA compared to placebo. Next slide. However, the effect of TPA is also time-dependent, just like tissue injury in the brain is time-dependent. So as the tissue injury is increasing, the benefit of TPA also decreases with time. So the best outcomes were seen in the earliest arriving and treated patients, and that odds of good outcome decrease precipitously, reach a point where it's no longer statistically significant, around 270 minutes or 4.5 hours. So for every 10 minutes that went by without TPA, one fewer patient out of 100 actually experiences benefit from the TPA. So it's very important to keep that in mind. So since that trial, and obviously many other studies since then, there's a great deal of emphasis on increasing TPA utilization. In fact, we know that there have been improvements over the last decade from as low as 1 or 2% to contemporary use of TPA hovering around 5 to 6%. That is an improvement in large part due to better awareness, reducing number of stroke centers, pre-hospital strategies to bring patients to stroke centers, and improved quality improvement in the emergency departments. However, you can see here that there is an opportunity to further improve TPA treatment. As many centers have shown, you could get potentially up to 20% of your patients treated with TPA, since many of them do have disabling deficits and arrive in the 3 and 4.5 hour time windows. So it's the amount of gap or potential room for improvement in TPA delivery or utilization that I think we're trying to emphasize and impress upon colleagues around the country. Next slide. And in many ways, that was the origin or the impetus behind this scientific statement from the American Heart Association, American Stroke Association in 2016. This group came together to review all of the many exclusion criteria that had been in the prior statements from the American Heart Association, as well as in the FDA package insert for Alteplase, and provide some more guidance as to whether the criteria were born out of clinical evidence or whether they might actually be reversed as new data had emerged since 1995. So with that, I want to spend the next 10 minutes or so reviewing some of these and hopefully bringing up at the end an opportunity for discussion around some of the less common criteria that also use of whether we should consider TPA or should withhold TPA. Next slide. As Renee mentioned earlier, the most common reason why patients are not given TPA when they are eligible is that they're deemed too mild, rapidly improving, the so-called too good to treat group. And there have been several studies on this that have shown that this group in particular may be actually more to be disabled than previously believed. In fact, a summary of the prior published literature suggests about 25% of people who are too good to treat and do not receive TPA because of too mild or rapidly improving stroke symptoms end up being disabled at long-term follow-up. That is an alarming rate, considering that there was an opportunity to give them TPA and the drug was not provided for a whole host of reasons. So that one, I think, is one I want to highlight and review in more detail. And then age. Age continues to be a reason why patients aren't treated with TPA, and I'll review the literature that supports the benefit of the drug in patients who are older than the age of 80, sometimes thought to be too old to receive TPA and may not benefit as much, or the risk of TPA is too high. And I'll show you some data that contradicts that. There are a number of other reasons, and you can see some of them relate to, for instance, able to determine eligibility. That's, history taking, identifying family members or witnesses. That can be difficult, and there may be ways around that. Likewise, a person has CT changes or has findings that are contraindications to TPA because of bleeding risk. We'll talk about some of those may be hard to reverse because of potential harm that TPA could cause. Going to the next slide. I'll talk a little bit about these two in particular. Those are age as a contraindication and stroke scale, using the stroke scale as a barometer of who should get TPA and who should not. You can see from this meta-analysis of TPA versus placebo that in those over the age of 80 compared to under the age of 80, the benefit of getting TPA is present in both age groups. And I'll show you another slide how that can be despite the fact that older patients tend to have worse outcomes in general. For instance, the Alteplase group, 17.6% had outcome compared to 13.2% if you're older than 80. You can see that is substantially lower than either of the rates in the under 80 group. So what's happening here is that there is an overall effect of less good outcomes if you're older, but there is still a differential benefit of TPA over placebo in the older group. That's what's seen here, is that there is a benefit even though the overall chance of a good outcome is less when you're older. When you look at the NIH stroke scale score, you can see in that though most of the people treated were not severe, only around 600 individuals could compared in the 22 and higher stroke scale score. There is still a significant benefit of getting TPA compared to not getting TPA. Once again, of course, NIH stroke scale score drives outcome such that people with higher NIH stroke scale scores have a less chance of having a good outcome. It's what you're seeing as you go from one strata to the next strata. They're just less likely to have good outcome in either group. But in each time, in each group, TPA gives them a slightly better chance of a good outcome than not getting TPA. Let's drill into that a little bit more into the next slide. Whoops, didn't come right, but I'll show you, I'll I'll talk about what was behind it. This, for older age, what the studies had shown previously was that, once again, better outcomes are seen in younger people than people. Again, not a surprise. Age is a very strong predictor of outcome in general in stroke patients. However, guidelines now state very clearly, based on the meta-analyses that have been done, that although older age is an adverse prognostic factor in stroke, that it may also be associated with higher mortality and higher rates of symptomatic hemorrhage compared to younger than 80 years of age. TPA, or intravenous alteplase, provides a better chance of being independent at 3 months across all age groups, including those greater than the age of 80. So it's a class 1 level of evidence A, the highest level of recommendation that can be made. And that's now the statement that we should all try to adhere to when we think about excluding people based on age alone. The only thing we should focus on, and again, the most common reason for exclusion, is mild stroke and rapidly improving stroke symptoms. These, again, are very commonly documented. There may be, again, reasons why this may be falsely documented. So it might be due to the notion that an NIH stroke scale score of 0 to 4 is, or 0 to 5 is by definition mild. We all know that's not true. We know that people with aphasia, for instance, a language disorder, might have a low NIH stroke scale score, but it could be quite disabling and not be, in fact, mild at all. And so the idea that you can use the NIH stroke scale score to determine somebody as being mild is probably flawed from the outset. Likewise, rapidly improving symptoms should be carefully defined as a group of patients in whom symptoms have reversed and improved to the point of being non-disabling. So a person who starts off with an NIH of 20 and comes down to an NIH of 10, yes, they have improved substantially, but their NIH at the time that you're evaluating them of 10 suggests significant disability potential. So that person should not be considered rapidly improving. I noted earlier, about 25% of patients in these categories end up having disability at 3 months. So they're not so benign, and we have to be very careful about excluding these individuals from treatment. The slide also has a graph that shows how the rate of disability at 3 months looks in each score item. So in a person with an age of 1, 2, 3, 4, 5, you can see here again a substantial proportion have disability, and it rises up to almost 40% if looking at the NIH of 5 and calling those people mild and not worthy of TPA. The FDA, as I'll point out in their label in changes in 2015, I think, I can't remember, moved these exclusions should, again, now leave us with making this decision based solely on whether we think someone is going to be disabled or not at the time of presentation. So I want to go to the next slide. I'll show you what I think, based on some consensus criteria, should be used when we make that assessment. So it's based on the TREAT task force. They published this a few years ago and helped us define what one should consider disabling and what one should consider improvement to the point of being rapidly improving. So the first point is improvement should be such that remaining deficits seem non-disabling, and the following should be considered disabling. And hemianopia, so you can imagine somebody who has a visual cut, will be unable to read, unable to drive, have a disability related to visual loss. So a person who has a complete hemianopia, that should be considered disabling by most in most situations. A person who has severe aphasia, greater than 2 points on that question for aphasia, or a extinct or neglect finding on vision or sensory testing, or weakness such that they're not able to sustain against gravity, greater than or equal to 2 on any of the motor questions could be considered disabling. Any deficits scoring greater than 5, if they add up to greater than 5. And then, of course, clinical judgment. And I always point this out. For instance, here I am giving a lecture. You can imagine how if I were to have a mild stroke affecting my speech, whether it's slurring it or mixing up words in aphasia, how that might impact my ability to work or do these kinds of activities. So if I came in with a NIH stroke scale of 2 for aphasia or dysarthria, I would think that the treating physician would consider my livelihood and consider what I'm presenting with as disabling. Next slide. That sort of is, I think, the context behind mild stroke, how to use your clinical assessment to increase treatment of mild and rapidly improving strokes so that you're really treating people who have any potential for disability. How about the other end of the spectrum? I showed you the composite data for the likelihood of a good outcome in those treated with TPA versus not, and across the different stroke scale data, it was present. In the oldest group, in the most severe group, rather, you can see greater than 20 in this slide. There is still a difference in the chance of good outcome in those that got TPA compared to those that didn't get TPA. And relative benefit, and the line show you exactly how much of that benefit is preserved across the different data. Next slide. So final 2 slides here. I'm just going to emphasize what this group, this committee that evaluated the exclusion criteria and tried to come up with different guidelines for each of them did was they applied levels of evidence and class of treatment effect to all different exclusion criteria and provided clinicians with some guidance to which of those might be reasonable to treat and which of those still remain contraindications. So next slide. A summary. This is from Eric Smith, who was on that committee with me. You can look at this as a color code cheat sheet in terms of which of the contraindications previously noted are actually now reasonable to consider treatment or level of evidence A for treatment. I mentioned older age. I mentioned high stroke severity. I mentioned mild but disabling symptoms and improving but disabling symptoms. These are all ones that I think now, with the evidence behind it, have raised themselves to level of evidence A, such they should really be treated. Early CT changes I did not mention in this presentation, but also has been reviewed, such that subtle but not frank ischemic changes, such as established hypodensity or mass effect, those patients should be treated. It's really those with extensive changes, either using the aspect score or other ways of looking at midline shift or swelling. It's the set of people that have those changes that should be excluded from TPA, but those with mild or minimal changes, which many of our patients have, should be offered treatment. I point out in light green that there are a number of situations where it's potentially reasonable to consider it based on the situation that you're encountering. And the reason why the writing group could not come up with stronger statements is because there's just simply a lack of data, a lack of evidence to say one way or the other that this was incontrovertible. So you might have situations where somebody comes in with a history of a MI in recent months, and you find out that was really just a troponin leak or non-ST elevation MI. Those patients probably should be considered for treatment, again, balanced against stroke symptoms and their stroke disability potential. So if somebody comes in with a left MCA syndrome and a non-ST elevation MI a month ago, I might consider treating that patient because the benefit of TPA may outweigh the potential risk to them insofar as heart. Likewise, situations such as having a existing disability, it might be weighed against, well, how functional are they? Would they be returning back to a reasonable level of function if their stroke symptoms were reversed? Or somebody had recent bleeding in their stomach, but it was controllable, or it was something that surgeons feel like could be stopped if needed. Those might be reasonable to talk to a consultant and immediately decide whether that person could be treated. We've done that on many occasions. This is, again, a nice cheat sheet. You can use it to really guide and help your clinician say, hey, this is actually not a contraindication. This is where there's room for consideration of TPA and could be made on an individualized basis. And the ones that are in red remain pretty strong contraindications. And I just want to point out again, the FDA independently, not related to this committee, and not related to a request from the makers of Alteplase Genentech, independently because of some internal regulatory considerations, they actually provided a new set of guidelines in 2015, different from 2003. And the major ones that are listed, if you look at the comparison, was that they removed prior ICH as a contraindication in the label. They removed seizure, mention of seizure, glucose, stroke severity, and CT evidence. They removed those because of the potential of over-interpreting them, and qualified what I mentioned earlier, that the elderly may benefit from TA, and so that's now there as a qualified statement that age greater than 77 was one of the several interrelated baseline characters associated with increased risk of hemorrhage. However, efficacy results suggest a reduced but still favorable clinical outcome for elderly. And then they removed the blood pressure criteria, which had been confused for many of us in terms of cutoffs of blood pressure, and then just leave it to your own judgment of what you think uncontrolled is. And that's because several studies have shown that if you can control it with any number of means, there doesn't seem to be any harm associated with the choice of what you use to control their blood pressure. So it is eye of the beholder there in terms of what that means. Next slide. A final summary. It's detailed. You can use it as a reference, and that sort of summarizes the different statements that are out there. There's a guideline statement from the AHA, which was, of course, amended with the scientific statement in 2015, and then there's the old versus the new package inserts based on the FDA. So again, this is a nice summary of what's changed, and could be distributed to team members to make sure they understand why and what's now current compared to before. Okay, that was my presentation. I hope you got a lot out of it, and if you have questions, I'm available now if time permits or by email.
Thank you, Dr. Prabhakaran. That was a fantastic presentation. We just have a couple of quick American Heart Association, American Stroke Association announcements before we'll take questions for our speaker today, as well as if anyone has questions for Renee or I. So just off with, we wanted to congratulate our Midwest Gut with Guidelines Stroke Hospitals. We know several of you are joining today, and our award announcements have recently gone out in the last couple of months since we've had our webinar. So we wanted to congratulate all 227 of our Midwest hospitals that were recognized for a Gut with the Guidelines Stroke Award in 2017 based on their 2016 data. Of those 227 hospitals, we are really proud that 166 of those were also receiving a target stroke recognition, recognizing their efforts for improving door-to-needle initiatives. So thank you so much to all of you that joined today for all of your hard work in adhering to our guidelines. Next slide. We do a quick reminder. I think many of you on the call
In the question and answer session, participate over the phone. If you'd like to ask a question, please press star 1. Please unmute your phone and record your name clearly when prompted. Your name is required to introduce your question. To call your request, please press star 2. Once again, participants over the phone, if you would like to ask a question, please press star 1. One moment, please, while we wait for the first question.
This is Renee, and Lynn still had a few announcements before the question and answer session. Thank you.
Can you hear me okay?
Yes.
Okay. So just a couple more announcements before we get to questions. There was a one-pager that went out in your confirmation email today just to let all of you know about our Get With the Guidelines AFib program. There is funding available for hospitals that are interested in filing this out at the end of the year. It's a great resource for you to be able to do quality improvement within your organization in regards to patients with atrial fibrillation and help manage those risk factors for our stroke patients. Next. About our patient support network. This is a great free resource for all of you and your patients. If you are not able to host an in-person support network in your area or want to use this in conjunction with your in-person support network that your hospitals might offer, this is a free online support network. There are several different disease processes that patients can join their support networks, be able to ask questions about their disease process, talk with other patients and family members that have gone through similar experiences. This free online support network, there are also resources for facilitating an in-person support network on this page, including a year's worth of agendas and discussion topics. So let all of you know about that resource as well. Thanks. And then in regards to stroke, there are some great resources that are available to you to use with your organizations and also for doing community education related to stroke. Our stroke simulation event toolkit link is on here, as well as our FAST resources. So please feel free to access those and use them to help support your education efforts within your hospital. And just about our upcoming stroke-related events throughout the Midwest. So July 27th, we have a Abstracting Stroke Data That Will Work For You course in Michigan. This is geared towards abstracting data into Get With the Guidelines Stroke and helping to advance your confidence in those skills. And the registration for all of these links can be found in the PDF copy of your slides that you received today, and we will send that out again this afternoon. October 4th, we're really excited to have our next Midwest Affiliate Quarterly Stroke webinar. Topic will be on stroke certification, all your questions answered. We will have Laura Reese, our National Center Accreditation Manager, available to answer all of your questions related to stroke certification. So please feel free to register and submit your questions early. There is a spot in the registration form to submit your questions. November 3rd, here in Wisconsin, we will have a, I believe, 4th round of abstracting stroke data that will work for you course. Third, there is an annual Bi-State Stroke Symposium in Overland Park, Kansas. Scientific Sessions Conference taking place November 11th through the 15th in Anaheim, California. And it's too late to submit an abstract for scientific sessions. We encourage all of you to submit your science to International Stroke Conference. It's January 24th through the 26th in Los Angeles. A abstract submission deadline for that is August 1st. All respective links for these events are in your PDF copy of your slides today, and you can also go to heart.org/MWAQSI events for any Midwest affiliate-related stroke events. All of you so much for joining today, and now we will open up the Q&A session of our webinar today.
Participants over the phone, if you would like to ask a question, please press *1. Please unmute phone and record your name when prompted. Your name is required to introduce your question. To cancel your request, please press *2. Once again, participants over the phone, if you have a question, please press *1. One, please.
And we have a few questions that have come in through the Q&A chat box, so I'm going to try and read them one by one and then pause to see if we have any questions coming in verbally. So the first great question, it asks, will there ever be an option for if symptoms completely resolve instead of stroke severity too mild? And provide a response, and then Dr. Prabhakaran, if you have anything to add, please feel free. So there is a separate question in the patient management tool asking if symptoms completely resolved upon presentation, and there's an option to check yes, and that will exclude the patient from the measure. And this is the same if the NIH stroke scale is documented as 0.
Yeah, I would caution, that we obviously trying to increase TPA utilization, but the group of people that have non-disabling or no deficits, there is then, of course, the risk of harming them because they're now normal or not disabled, and you're giving them a drug that has the potential of causing harm. I think it should be always weighted against those symptoms likely to be disabling. In the absence of that, I think you have very little supporting evidence to treat with TPA.
Chris, are there any questions that have come in through the line?
Question from Jeannie. Ma'am, you have an open line.
It's a question. At our establishment, we will use Penumbra as a deciding factor if somebody should get TPA, somebody shouldn't. Even it doesn't necessarily show a stroke on the CT. If there's no Penumbra to save, they will not get or very rarely give it because we do CT, CA, and CT perfusion on all our stroke codes. Is going to put a place where you can say, no Penumbra noted. So you're not going to give TPA if there's nothing to save.
I'll make a comment about this. I think this is potentially an emerging area of interest. Many people have obviously pushed on the use of Penumbra for delayed presenting patients. I would caution that early use of perfusion imaging sometimes underestimates both the core and sometimes can also evaluate the Penumbra. So how certain you are that your measurement of Penumbra using imaging in the early period is really unknown, and it is deliberately not in the guidelines as a way to select patients because of that uncertainty. So I really caution against doing that unless new data come out supporting that. I think the premise is fine. Whether the test actually provides us the information with the highest amount of reliability is really not proven at this point. And so I caution against within TPA in somebody otherwise eligible for it solely because an imaging study showed there was no tissue that was at risk.
Just charting that. Now, obviously, if the person is having major signs and there's no perfusion, but that infarct is not there yet, that's not to say that they wouldn't treat. But if somebody that, it may not be the greater than 1/3 infarct, it may be that there's an infarct there, it's a small infarct, and there's no penumbra, even though they're well within the window. There's no cutoff for on the CTA.
Yeah, my worry there is again the reliability of those measurements for and penumbra in that setting. What if you're wrong? What if there is?
How to document that when that is the reason that they're giving?
I wouldn't know. I would imagine that it would mean that you're saying that there's an established infarct, and that's why I think that's why the guidelines won't find a way to justify it, because there really isn't justification for it.
Okay, thank you.
So, great question, and I believe, Jeannie, that there is an option for other reasons, and so there is a place for you to document, and we can get back to you on that. And
I've put that in, but okay, all right.
That's a great question. Thank you.
Yeah.
And I'm sorry, Lynn.
Oh, go ahead.
Sorry to add to that, Jeannie. I think that when you're documenting that other reason, that would be an option for you to check that within your hospital and be able to run your trending reports. But just as Dr. Prabhakaran mentioned, that would not exclude the patient.
Exactly. So, based on their decision to not give it because of their test that they found. So,
for your group to review. I think it's an opportunity for your group to review the data around this and perhaps reassess that decision making.
And we kind of look at it as forward. We're using perfusion as a basis, because sometimes we actually give it. The NIH is a 1 or a 2, and we use the perfusion to go, oh my goodness, they have a low NIH now, their perfusion is huge. There's a mismatch, and then we give it. Not to just exclude it, it really is to include as many patients as
correct. I understand. I'm just saying I'm not sure the reliability of that information at the early window is as good as you think it is.
Okay.
Great discussion, and I want to answer a few more of these questions real quick before we check on the line. So first of all, copies of the presentation will be available. They'll be mailed out, and we are recording this webinar, and we will send a link with that recording at a later time. So to answer those two. Okay, I'm going to go through, read one more longer question. With these findings, does this indicate that, so those abstracts get the guidelines, if they see a patient, and I'm sorry, okay, they see when a physician or nurse practitioner writes no TPA due to elderly age, are the guidelines saying that the abstractor should no longer consider this as an acceptable reason, that they no longer select the life expectancy option? Is that something you can comment on?
I think expectancy is a reasonable thing to consider. It's sort of, the judgment of, is this person likely to benefit long term? Are they so disabled that, at their line pre-stroke, that the life that you're getting from TPA is just not worth it. I think it's still reasonable to have that discussion with the family and
And Chris, have there any other questions coming in through the line?
At the time, there are questions on queue.
Okay, hand it over to you to select another question to read from the chat box.
Okay. So let me see here. So I do see one asking, is ASA going to adopt BFAST? I've had received several questions about this over the last few months, and I can let you know at this time we are not going to adopt BFAST. And Dr. Brockern or Renee, if you have further comment on this, please feel free. But at this time, we are not going to be adopting BFAST until further studies are done. We will not change our messaging based on the one study that was published.
Further studies could help, but I do think it's potentially useful.
Here for some more questions. I see a question about sending out certificate participation. We do not offer CEs for these webinars, but if you need something notifying, stating that you attended the webinar, we can send you an email with our attendee list if that's something that you need, but CE is not offered for this. All the questions that have come through the Q&A, if there are any others on the line, Chris, let us know.
We have one question on the line. Lynn, ma'am, you have an open line.
Lynn, we're having a little bit of trouble hearing you. Can you hear us?
Hello, do we have a question? Okay, I don't think we're getting the participants' questions, so we can wrap the call. And if anyone has further questions, please feel free to contact Renee or I, and we'd be happy to address them by email.
Yes, everyone, and we will double check our Q&A box and be sure to contact you if we didn't have a chance to get to your question. Thank you, Dr. Prabhakaran, for a wonderful presentation. And again, we will be sending out these slides, and this is a recorded webinar. Hope to see you on October 4th. Thank you.
Thank
you. Ms. Milgren.
My pleasure. It was really an honor, and I'm glad we had a great showing. It's terrific. Thank you.
Thanks, and that concludes today's conference. Thank you for joining. You may disconnect.